let's jump straight into the clinical material. In this explainer, we're breaking down the exact pathophysiology, diagnosis, and receptor-targeted management of narcolepsy. Consider this an integrative simulation, calibrated strictly for a perfect 280-plus board score. We're going to be detailing intricate mechanisms, discrete management steps, diagnostic traps, key markers, and absolute exceptions. So, let's get right to work.
All right, let's dive into the orexinergic collapse. Narcolepsy type 1 is strictly driven by an autoimmune wipeout of the lateral hypothalamus. This targeted loss of critical hypothalamic neurotransmitters, specifically orexin, which you might also know as hypocretin, literally destroys the brain's ability to sustain wakefulness. You see, orexin is the neuropeptide absolutely required to keep the brain awake, and it fundamentally inhibits REM sleep phenomena from occurring out of sequence. When you lose orexin, you completely lose the structural integrity of the sleep-wake boundary.
Now, when diagnosing this collapse, sure, most cases are clinical, but you absolutely must know the definitive biomarker. In equivocal presentations, the absolute non-negotiable diagnostic marker actually requires a lumbar puncture. What we are looking for are profoundly low or even completely undetectable levels of CSF orexin A, again, hypocretin 1 in the cerebral spinal fluid. This is the ultimate undeniable biochemical proof of that hypothalamic destruction.
Picture a 22-year-old college student. She goes to bed at midnight, wakes up at 8 a.m., and theoretically gets a perfectly restorative 8 hours of sleep. Yet despite that, she suffers from devastating sleep attacks, literally collapsing at her desk right after lunch. The clinical hallmark you need to recognize here is profound daytime somnolence despite totally adequate sleep duration. This kind of presentation mandates a very specific pathway to rule out organic mimics like obstructive sleep apnea, and it points us straight toward polysomnography.
Think about normal sleep architecture for a second. It securely delays the onset of REM sleep to about 90 minutes. Well, narcolepsy fundamentally destroys that barrier. When we run the multiple sleep latency test, the polysomnography strictly reveals an aborted latency period. This confirms a drastically shorter time from wakefulness to the initiation of REM sleep. Instead of that normal 90-minute wait, REM sleep violently intrudes within just 15 minutes of sleep onset. That aborted REM latency, that is the absolute physiological signature of the disease.
So what actually happens when REM sleep just can't be contained? Without orexin, you get these violent, abnormal transitions from wakefulness directly into REM sleep. This basically bleeds sensory and motor dream sequences right into the patient's conscious state. It's like your brain's dream hardware booting up while you're still completely awake. We see the perceptual bleed of hypnagogic hallucinations as the patient falls asleep and hypnopompic hallucinations as they wake up. We also see sleep paralysis. But the absolute most specific REM intrusion is cataplexy. That's the sudden, bilateral loss of voluntary muscle tone strictly triggered by intense, sudden emotion. Classically, we're talking about laughter or profound surprise.
Listen, it is absolutely critical to distinguish a cataplectic strike from a generalized seizure or a drop attack. This is a classic diagnostic trap. In a cataplectic strike, we have what I call the consciousness mandate. Consciousness remains completely intact while the patient is paralyzed, which perfectly mirrors the physiologic atonia of REM sleep, just occurring while they're awake. Plus, the EEG during cataplexy shows awake or REM patterns. On the flip side, an atonic or generalized seizure is unprovoked, consciousness is strictly lost during the event, and it's inevitably followed by a confused postictal state. You have to secure this clinical variance in your mind to avoid a very dangerous misdiagnosis.
When it comes to management, it is strictly bifurcated into two receptor-targeted pathways. Keep in mind, stimulants do absolutely nothing for cataplexy. So, to manage the excessive daytime somnolence, we deploy CNS stimulants like modafinil, amphetamines, or the top-tier agent pitolisant. Pitolisant is a highly specific histamine H3 receptor inverse agonist that strictly amplifies histamine-driven wakefulness. However, to suppress the REM atonia intrusions of cataplexy, the absolute mandate is a totally different receptor target. We specifically deploy REM-suppressing antidepressants like SSRIs or venlafaxine. Alternatively, we utilize sodium oxybate. That's a powerful GABA-B agonist dosed strictly at night to consolidate sleep and actively prevent daytime structural collapse.
All right, let's translate all of this into a master case blueprint to test deep clinical integration. Here is exactly how we engineer the scenario. We profile a 22-year-old female college student who suddenly collapses to the floor at a comedy club. She's physically paralyzed for about 30 seconds, but she perfectly remembers the punchline her friends were laughing at. She also has a 6-month history of falling asleep during midday exams. Now, to really test conviction, we embed a severe diagnostic trap. We introduce a newly discovered, totally innocent grade 1 out of 6 systolic murmur, along with a family history of sudden cardiac death. This blueprint aggressively tempts the test taker into diagnosing cardiogenic syncope or a fatal arrhythmia like long QT syndrome. But the student must recognize the preserved consciousness to completely bypass the cardiac workup.
The prompt will strictly demand the precise pharmacological mechanism required to prevent her specific structural collapse. To secure a top-tier score, you must actively navigate this exact 5-option matrix. Option A, sodium channel blockade. Incorrect, because this is not epilepsy. Option B, beta-1 adrenergic antagonism. This is a lethal structural mimic trap targeting that innocent murmur we threw in. Entirely incorrect. Option C, dopamine reuptake inhibition, like modafinil. Incorrect, because as we discussed, stimulants do absolutely nothing to prevent a cataplectic strike. Option D, direct dopamine agonism. Incorrect, that specifically targets Parkinson's disease. That leaves option E, serotonin reuptake inhibition. You must actively select an SSRI or alternatively a GABA-B agonist like sodium oxybate to exclusively target and suppress the atonia. I'll leave you with this final thought. True clinical mastery isn't just knowing the right answer. It's understanding exactly how the wrong answers were designed to deceive you. Can you strip away the clinical noise to find the exact neurochemical target?